Hi, thank you for joining me today. Today, we're going to talk about new and emerging biologic agents for the management of chronic rhinosinusitis with nasal polyposis. And we're going to talk a little bit about the pathophysiologic insights and patient selection during this presentation. I am Joseph Hahn. I'm currently a professor at Eastern Virginia Medical School, the chief for the Division of Rhinology and Endoscopic Sinus and Scopio Surgery. I'm also the chief for the Division of Allergy within our medical school here in Norfolk, Virginia. So these are my disclosures. So these are the learning objectives for today's discussion. So we're going to review the pathophysiologic and immunologic molecular drivers for chronic sinusitis, talk about the different approved biologic treatment for the treatment of chronic sinusitis with nasal polyps. And then we're going to incorporate individualized and patient-centric focused care for our patients with CRS with nasal polyps. So let's start off with a pretest question. Nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? Interferon gamma, tumor necrosis alpha, IL-6 and IL-8, IL-4, IL-5, IL-13, IL-12, IL-17, IL-33. So go ahead and make your selection and go ahead and submit your answer. All right, let's go ahead and ask another question. The immunogenic nature of CRS with nasal polyp is typically characterized as type 2 inflammation driven by eosinophils. However, many patients with severe disease show which of the following: um, higher levels of type 1 cells and type 1 inflammation, more neutrophils and eosinophils, mixed levels of eosinophils and neutrophils, and greater number of macrophages and CD8 T cells. And so go ahead and submit your answer. All right. And then here is another question. A woman in her late 30s present with nasal polyp and a history of eosinophilic asthma. She has a low IgE and doesn't want surgery. So which treatment would be appropriate? Benralizumab, mepolizumab, omalizumab, or rezolizumab? And go ahead and submit your answers. Okay, here's another question. A 49-year-old male with severe CRS with nasal polyp is scheduled for endoscopic sinus surgery next week to have polyps removed. Um, when when should he be first reassessed for response for the treatment per the Euphoria guideline and the multidisciplinary consensus algorithm? Anytime within the first 6 months, at 6 months, between 6 to 9 months, or anytime after 1 year. So go ahead and submit your answers. Okay. So here's another question. A 53-year-old male with CRS with nasal polyp who has undergone endoscopic sinus surgery twice returns after 12 months of trying one of the biologic. He showed inadequate treatment response per the Euphoria criteria and he believes his endoscopic sinus surgery were a waste of time because of polyp recurrence. What would be the most appropriate recommendation with shared decision making and consensus guideline? One, switch to different biologic, continue biologic for another 3 months, go for revision sinus surgery, and stop the biologic and back to medical management. Okay, so we're done with the pre-test polling questions. And so let me go ahead and go further. So let me talk about CRS and CRS with nasal polyp. So we know the prevalence of chronic sinusitis with and without nasal polyp in the US is very high. And actually, according to the CDC, we have about 29 million adults in the US that has the diagnosis of chronic sinusitis. Now, we break those patients up based on the phenotype with the presence of nasal polyps. So we break it into patients with CRS with polyps and CRS without nasal polyp. Now, those with CRS with polyp make about a quarter, a fifth to a quarter of those patients with CRS. Now, technically, it may be higher, but the only reason why it's about 20 to 25% is because we have to be able to document the presence of nasal polyps. And so, if the polyps are in the sinus cavities, like ethmoid sinus cavities, and you can't see it, then they would be CRS without nasal polyp. And we know that CRS without nasal polyp is a little bit higher among men, while CRS without nasal polyp is a little bit higher among women. But if the person has nasal polyp and asthma, it tends to be a little bit higher among women. So when we think about chronic sinusitis, the symptoms is very characteristic and almost diagnostic of of diagnosing somebody with CRS. And these symptoms, the four most common symptoms associated with CRS is nasal obstruction and congestion, nasal secretion or postnasal drainage, loss of smell, and facial pressure. And those without nasal polyp tend to have more facial pressure, while those with nasal polyps tend to have more likely have loss of smell. Now, it's not surprising for those who treat patients with chronic sinusitis that these patients are miserable. I mean, these patients have a poor quality of life. The fifth most common symptom is deprived sleep quality. And these patients, when they have sinusitis, I mean, a lot of them will still go to work, but they have decreased productivity at work. And it tends to be a very high social disability among our patients because they're constantly blowing their nose and feeling congested. And because it's high and the quality of life is also high, we see that there is a tremendous amount of cost utilized to treat these patients. So the direct healthcare cost could be anywhere from $7 to $10 billion a year. And that's not including the indirect costs. So for patients who have sinusitis, go to work, and are not able to function properly. So that can be even higher. And so you can see that there's a tremendous amount of money used to treat our patients with CRS with nasal polyps. And I do want to mention that if you have nasal polyp, you're more likely to have more office visit, more likely to use more medication, and obviously more likely to have sinus surgery as well. Now, what are our typical standard of care for treatment of nasal polyp? And there are several publications that have come out that have said that there's a lot of evidence to show that nasal steroid spray is effective in CRS with and without nasal polyp. Same thing with saline irrigation is also helpful, as well as some non-traditional steroid delivery, topical steroid delivery. Certainly, systemic steroids is a very effective options in our patients with nasal polyp, but it has a lot of drawbacks and complications, especially with long-term use. So those are things that we don't like to use very often. And of course, after they failed medical therapy, these patients are appropriate for sinus surgery. So let's look at a patient, a few patients, typical patients that we see with CRS in our office. So this is Jason, 50-year-old man, history of nasal polyps. And in these clinical studies, um, in our clinical studies where we look at patients with CRS, actually, these patients have had CRS with nasal polyp for about 10 years or more. So these are pretty, so 4 years is not a long time. And it's not uncommon that they would have associated or comorbid allergic rhinitis. And usually, if they do have allergic rhinitis, it tends to be during childhood years. The presentation tends to be when they're a child. And if you check for specific IgE, they tend to be associated with dust mites and cat dander. Now, these patients, because nasal steroid spray in the US is over the counter, a lot of these patients with nasal polyps have already tried nasal steroid spray before they come and see us. And so before it was over the counter, a lot of these patients tried mostly saline spray and saline spray and irrigations. But now that nasal steroid sprays are over the counter, that's a very commonly used medical treatments before they come and see us. And we know it doesn't work. Nasal steroids just doesn't is not effective for CRS with nasal polyp, and so they have to choose other treatment options. And the other treatment option is a short burst of systemic steroids, and often with or without antibiotics. And so you can see that this patient is miserable and wants more treatment. So, and we know that sometimes when they use like the nasal corticosteroid spray, it's just not effective. And when it's not effective, they just don't use it as often. And in fact, they'll often stop using it. We know that saline irrigation is effective, but if you have polyps blocking the sinus drainage, it just doesn't work. And of course, systemic steroids is effective, but it just has so many side effects, especially with long-term use. And so, what do we talk to this patient about? And so, what I tell patients, when they have CRS with nasal polyp, I say, in order to effectively treat your nasal polyp, we have to understand what's causing it. Because without understanding what's driving the presence or the prevalence of the nasal polyp that you have, we're not going to be able to appropriately treat these patients. So, I talk to them about the different type of inflammation, what is the different comorbidities and how it's associated with it. And, I talk to them about the different risk and benefits with a different type of medical treatment, like topical steroids or systemic steroids. So let's look at another patient, Angela. She's a 41-year-old female diagnosed with CRS not too long ago, about 2 years ago. And it was so bad that she underwent sinus surgery. And the polyps came back, within a year. So that already tells you that this patient has a pretty severe nasal polyp disease. It is not uncommon that these patients with severe nasal polyp have comorbid asthma. And, when these patients with nasal polyp and asthma, one of the questions that I ask is, do you have asthma? And if you do, at what age did you get the asthma? Because, we've seen patients with a late onset asthma diagnosis without a history of atopic disease tend to maybe be or eventually develop into aspirin triad or ARD patients. So this patient was diagnosed later on in life at the age of 25. And then if they have nasal polyp and asthma, I commonly check for blood eosinophils. Her blood eosinophils is elevated, and her total IgE is on the low side, is below 100, is 40. And her FEV1 is 70%. So even her asthma is not well controlled. And that's important to know. So these patients with nasal polyp, you want to make sure that they have, whether or not they have asthma, and ask if their asthma is well controlled. And so for something like this, certainly with pretty severe disease, sinus surgery is an option. And if it comes back, then what do you do? And one of the things that I talk to patients about is if you have CRS without nasal polyp, I say that sometimes sinus surgery can effectively cure you of your nasal polyp. And it doesn't necessarily have to be a chronic disease. But that's not true with CRS with nasal polyp. These patients with nasal polyp is a chronic disease. So if you're diagnosed with it at the age of 40, you're going to have it even at the age of 45. It's like hypertension. What I try to explain it to patients is it's like hypertension. Once you have it, you're going to have it for the rest of your life. You just have to be on medicines to help kind of control it. Same thing with CRS with nasal polyp. And we know, as I mentioned earlier, that women tend to be more associated with nasal polyp and asthma, and they are often seen a little bit higher among the African American. They tend to have a little bit lower onset, and again, there are more women than men. And these patients with comorbid asthma and nasal polyp tend to have more severe disease. And so again, with these patients, what I like to ask them, what I like to tell them is, what is driving the process? Because without knowing what's driving the process, we can't properly treat your disease. So let's kind of jump gear and talk about inflammation and immunologic drivers. So these are some of the reasons why these patients get nasal polyp, and we'll go into a little bit deeper dive regarding this. So we know that our understanding for CRS has gotten better. And I think we're all starting to understand that, it may be driven by epithelial dysfunction. So it starts at the level of the epithelium. Something triggers it and causes injury. And then inflammatory cytokines are then released and then causes the inflammation that we see in our CRS patients. And that's both CRS with polyp and without. And then when we look at the different types of inflammation, there are three categories: type 1, type 2, type 3. But when we look at CRS, we're starting to realize that maybe, not all type 3 inflammatory endotypes make sense for CRS. I think type 2 certainly makes a lot of sense, especially those with nasal polyp. And I think a lot of patients with CRS with nasal polyp tend to have a type 2 inflammation. Now, we can't say that for every nasal polyp patient because there are some nasal polyps that don't, but it's a very small minority. But majority of the patients with nasal polyp that have more of an inflammatory eosinophilic inflammation tend to be type 2, as we see here. And they're driven by cytokines such as IL-4, IL-5, and IL-13. Now, there are other groups of CRS that don't fit into type 2, and they're more type 1 or type 3, but I don't think there is really a good distinction for the other CRS. So I think now we're hearing people say it's either type 2 inflammation or non-type 2 inflammation, because we're starting to realize that type 1 and type 3 doesn't really fit well into some of our CRS patient endotype. And so these are some of the immunologic cells and cytokines that are involved in the development of nasal polyps. So we see that there are different allergens that can cause inflammation, and you kind of see that with the typical type 2 or Th2 inflammation. But we're also finding out that it doesn't necessarily have to be allergens that can trigger some of the type 2 inflammation. It could be something like a virus can also trigger that. We see that even biofilm and bacteria such as Pseudomonas and Staphylococcus can cause these type 2 inflammation. And they're usually driven by different alarmins such as TSLP, IL-25, and IL-33. And I think what we're starting to realize, it may be more TSLP and IL-33, although IL-25 is also discussed in the literature. And these are activate the innate lymphoid cell 2 or Th2 cells, then they release a different inflammatory cytokines such as IL-4, IL-5, and IL-13. We know that IL-5 and eosinophils kind of go hand in hand. IL-4 and IL-13 are seen in the allergic pathway, causing the transformation of the B cells, causing release of immunoglobulin that affects the basophils, mast cells, and release the allergic mediators. But we know that even IL-13 by itself can cause proliferation of mucus production of the goblet cells in the epithelium, as well as fibroblasts, and cause remodeling of the sinus epithelium. And we know that it's not clearly just a type 2 or a non-type 2. Sometimes there tends to be a little bit of overlap, as we see in the literature. There have been really nice work showing about the different types of inflammatory cytotype endotypes associated with CRS and CRS without nasal polyps. But I think what we're starting to realize is that CRS with nasal polyp is more type 2, while CRS without nasal polyp maybe type 2, but it could also be a non-type 2. And as we mentioned earlier, just because you don't see nasal polyp in the osteometal complex, you don't see it with a nasal endoscope, doesn't mean they don't have polyps in the sinus cavity that you can't see. So that's why it could be type 2 as well. Now, and like I said, it can certainly have mixed type 2 reaction. And this is some of the inflammatory pathway that we see in our patients with nasal polyps. So, seeing all that information, it makes sense that, we should be able to target these inflammatory cytokines. And we know that there are several monoclonal antibodies that have been developed to treat our patients with nasal polyps. So here are some of the FDA approved treatment options, biologics for nasal polyp. And so we have dupilumab, which targets the IL-4 receptor alpha, which then blocks IL-4 and IL-13. And then that was the first one that was approved. And we also have omalizumab that targets circulating IgE, and that was the next one that got approved. And the most recent one that got approved was mepolizumab that specifically targets circulating IL-5. And so you can see that the dosing ranges anywhere from 2 to 4 weeks, and these are the number of patients in the study. So let's take a little bit deeper dive into the efficacy of the different biologics. So let's look at dupilumab. And so the primary endpoints that were measured in these phase 3 study for nasal polyps was nasal congestion and polyp score. So let's look at those studies. So the 2 phase 3 studies for dupilumab for nasal polyp was Sinus 24 and Sinus 52. In Sinus 24, the patients were given dupilumab for 24 weeks, and then they stopped it, while Sinus 52, they were given the dupilumab all the way till week 52. So if you could see the change in the nasal polyp score on the top left, you can see that there's a reduction in the nasal polyp score. There's a sharp decline. And then at week 24, when it was stopped, you can see that the nasal polyp started going back up. But if you were given dupilumab for the whole 52 weeks, you could see that the nasal polyp continued to decrease over time. And if you also look at the bottom 2 charts, this is looking at nasal congestion. And you can see similar results like nasal polyp. When they were given dupilumab for 24 weeks, they had improvement. You see a sharp decline in their symptoms. And there almost seems to be a little bit of a sustained effect for about 2 months. And then you can start seeing the symptoms go up. While those who were given dupilumab for a whole 52 weeks, you can see that they continue to improve over time, whether it was given every 2 weeks or every 4 weeks, as you see on the bottom right chart. And then if you look at the use of systemic steroids and sinus surgery, I mean, that's what patients care about, right? So if you look at this graph, I mean, what this is showing you is patients who are in the sinus 24 and 52 study that were given systemic steroids or had undergone sinus surgery. And so, as soon as they asked for systemic steroids or underwent sinus surgery, that was a point. And you could see that the placebo group started to increase in the use of systemic steroids and sinus surgery, while the treatment group, those who were given dupilumab, did fairly well. And you can see at the end of 52 weeks that the placebo group was more than 3 times likely to take systemic steroids or undergo sinus surgery. And if you look at the safety data of dupilumab, is very safe. I mean, there isn't a lot of issues. The most common adverse effects is nasal pharyngitis. Otherwise, the other treatment related adverse effects is very low. So let's switch gear to another biologic, omalizumab. So as we mentioned earlier, the two primary endpoints for CRS studies have been mostly had two primary endpoints. One was nasal obstruction or congestion. The other was a nasal polyp score. And what you see here is a graph that shows the nasal congestion, and you can see that the two polyp study, polyp 1 and polyp 2, when you look at that the patients who were given omalizumab had an improvement in their nasal polyp score, as you see here. And you can see that the reduction is about a 1 point difference, as you see there. And you see a similar response in the nasal congestion or obstruction. So there is not only objective improvement in the nasal polyp score, but there's also improvement in the nasal congestion, as you see here. And you can see that the polyp score changed about 1, and you can see that the congestion changed about 1. And this was a scale of 0 to 3. So both the dupilumab and omalizumab, their congestion score was between 0 to 3. So these patients had moderate to severe nasal congestion. And by the end of week 24, which is when the primary endpoints were measured, they had almost a reduction of a change of 1 in that score. And here's the safety data. So again, similar to dupilumab, the adverse effect is very safe. And if you look at the adverse effect, I mean, there's like asthma, exacerbation, nasal pharyngitis. That's not an adverse effect of the biologic, but that's an adverse effect of the disease itself. These patients, if they get worsening of their symptoms, it's specifically due to the disease itself. That's why the placebo group is a little bit higher. So let's look at the last biologic that was approved for nasal polyps. So if you look at the way the data from the mepolizumab is presented, it's a little bit different than what we saw for omalizumab and dupilumab. And so we see here that this is a reduction in the polyp score. And so what they did was they looked at patients who were given the mepolizumab or a placebo group for a period of 52 weeks. And then what they did was see how many of those patients had an improvement in their nasal polyp score. So if you look on the top, which is the treatment group, they are more likely to have a decrease in the nasal polyp score, while those in the placebo are more likely to have an increase in the polyp score or no change in the polyp score. And if you look at how much improvement in the polyp score there was in the placebo group, you can see it's higher in the treatment group than the placebo group, especially those who had a nasal polyp score greater than 5 points, as you see on the table or on the graph on the right side. And similar to the dupilumab, they measured to see, the amount of patients between the placebo group and treatment group who needed surgery. And so what you see here is that the group that was given mepolizumab, that these patients by week 52 had a statistically um, a lower percentage of patients who needed sinus surgery. And you can see that by looking at the confidence interval. And so you can see that by week 36, maybe 36, and definitely by week 40 that they don't overlap. So you can see that they're statistically different by then. And similar to the other biologics we discussed, mepolizumab is safe in our patients with nasal polyp. Again, nasopharyngitis being the most common adverse effect. And again, it's not an adverse effect of the biologic, but more an adverse effect of the disease itself. Now, there are other biologics that are currently undergoing clinical trial. Benralizumab finished their Austral phase 3 study. Their ORCID is still ongoing, so it's not completed yet. There's also a biologic for tezepelumab for nasal polyp, and that is ongoing. And there's also another one, depemokimab, which is also currently ongoing as well. And so, if you look at the different treatment options and the different measures, um, we said that the primary endpoints was a change in the nasal polyp score and nasal congestion. But one of the key secondary endpoint is SNOT-22. And the reason why that's important is because SNOT-22 is consistent across the board. So that didn't change on any of the biologic study. And the way you usually decide whether or not there's improvement, clinical improvement, is to see a change in SNOT-22 from the baseline. And so this was calculated by Claire Hopkins, and they showed that the MCID, the amount of change in the SNOT-22 from baseline, the minimal amount that's clinically important is 8.9. And so if you look at dupilumab for the treatment group, so those who are given dupilumab, whether it be Sinus 24 or Sinus 52, you can see that there's a reduction of SNOT-22 by about 30 from baseline. So if you look at omalizumab and compare that from the baseline at week 24, it's about a little over 20 to 25. And if you look at mepolizumab at week 52, it's about 30. So you can see that all the patients who were given the biologic for nasal polyp, there was more than almost 3 times that of the MCID change in the SNOT-22. So these patients who were given the biologic definitely noticed an improvement in their symptom. And so the summary, kind of summarizing, the information, the efficacy and the safety data for biologics, I think, the biologics, based on the phase 3 study, showed that they are effective and a safe treatment options for CRS with nasal polyp patients. And if you look at the different endpoints, nasal polyp score, nasal congestion across the board, all three have shown efficacy, and that's why they got approved. Now, one of the things that was a little bit different for mepolizumab was how they measured the nasal congestion. As we mentioned earlier, dupilumab and omalizumab measured their nasal congestion score from 0 to 3, while mepolizumab had a visual analog score from 0 to 10. So instead of being 0 to 3 or 4-point scale, you saw that mepolizumab had 0 to 10 was 11-point scale, and that's how they measured the nasal congestion. And what's interesting is for me, actually, that's kind of how I measure our patients with sinusitis. And if I want to kind of figure out how they're doing, I actually ask them overall symptom score for VAS score, and then see how they do. And that's recently published in EPOS. We're certainly writing our papers discussing it, and it seems to be clinically helpful. And hopefully that paper will come out soon. And it showed that all three biologics had improvement in the SNOT-22 over 2 times, almost 3 times that of the MCID, or even higher than 3 times of the MCID. So let's go back to our case presentation. So, we presented the cases, we understood, well, just to kind of summarize what we've talked about so far is, we talked about CRS. We talked about what's causing the problem. We looked at our typical patients with CRS with nasal polyp. And like I mentioned earlier, you have to kind of figure out, what's causing it. And then the question is, well, then, if you realize that some of these inflammatory cytokines is driving the nasal polyp, how do we incorporate that? And so these are some of the publications, evidence-based publications that have come out. And so this is a multidisciplinary algorithm in the treatment of CRS with nasal polyps. So these patients who have failed topical steroid, what do we do for these patients? And I think, based on the experts from different national organizations that take care of patients with CRS with nasal polyps, they felt that the majority of patients should undergo sinus surgery, but there are certainly some patients that may need a biologic. So these are patients who don't want surgery or are not a candidate for surgery, such as with anesthesia. And there are some patients who have severe asthma that are steroid dependent. So certainly these patients, biologic may be the next option. But for everyone else, I mean, it felt like majority of these patients should undergo sinus surgery, give good postoperative medical treatment afterwards. And then if the polyps start coming back, this is where you need to have a multidisciplinary approach because a lot of these patients will likely have asthma and nasal polyp, and that's why having that multidisciplinary approach is helpful. And here are some of the treatment options that are commonly provided for our patients. So you can see here, and as we mentioned earlier, if you're trying to figure out, does the biologic work or not, I think that you should at least give it a 6-month trial because that's when the primary endpoints for all these clinical studies for biologics and nasal polyps were measured at. So, the experts feel that it should be at least 6 months before you decide whether or not it's working or not. And then with all these treatment options, I think it's important to have a shared decision-making process when you talk to these patients. Another way to decide whether or not a patient is a candidate for a biologic can be defined as patients with either uncontrolled CRS with nasal polyp or severe nasal polyp. And so here are the two definitions of uncontrolled CRS with nasal polyp and severe nasal polyps. And sometimes they can overlap. So what we're looking at, what we're saying and summarizing in the paper, Euphoria paper, is that biologics should be given to people who have failed medical treatment or have severe nasal polyps. And as we mentioned earlier, when we talk about shared decision-making process, this is available on both the American Rhinologic Society website as well as the American College of Allergy, Asthma, and Immunology website. So the American Rhinologic Society has a paper version, while the American College of Allergy, Asthma, and Immunology now has an electronic version. And when you go to the website, under the different interactive tools, you'll see one for CRS with nasal polyp. And, one of the things that we want to do when we talk to our patients, so this is a more patient driven shared decision-making tool. You want to kind of define to them, what exactly is CRS with nasal polyp? And you want to tell them, do you have sinus surgery or not? Because then you kind of separate that out. So going back to our patient, Jason, this is a patient with CRS nasal polyp, has allergy, doesn't have asthma, and certainly not getting better with systemic steroids. So, what tests would you consider giving this patient? And I would say if this patient has allergic rhinitis, history of allergic rhinitis and nasal polyps, certainly specific IgE is something that I would consider. Certainly total IgE or non-specific IgE is something that I would do. And I would say even blood eosinophil is, I think, a reasonable option for these patients that don't respond to medical treatment. And then, the question is, what would we, after understanding that, what's probably driving the nasal polyp for this patient is allergy, what would you do? And I would say, I think he'd be a reasonable candidate for sinus surgery. And I would talk to them about the different treatment options. Certainly sinus surgery is an option. I could talk to them about other treatment options as well. So, would a biologic be an option? Yeah. I mean, if the patient doesn't want surgery or if there's a reason why he's not a good candidate for surgery, I think certainly biologic could be an option. But I think this would be the patient where maybe, um, sinus surgery probably may be a good option, first option for this patient, especially if they've never had it. Now, Angela is a little bit different story. And so this is a patient I think may have eventually developed aspirin intolerance, right? She has adult onset asthma. She has severe nasal polyps, had sinus surgery already, and the polyps started coming back. And her eosinophils are elevated, 900. So, and her asthma is poorly controlled. So, this patient, is this a patient that you want to take to the operating room? And, unless her asthma is under better control, even the anesthesiologist may not want to put this patient to sleep. And so this patient may be a patient where you want to better control the asthma, and you may want to start off with a biologic because this patient already had sinus surgery, failed it, and is having the polyps grow back. And I think this is kind of where I think it's important to have a shared decision-making process. So, this patient, absolutely, I would draw total IgEs, measure specific IgEs to make sure. And I think for this patient, we already know that total IgE is low, so the specific IgE is likely to be less likely, but the total IgE is low. And then, I think, the question is, should we do revision sinus surgery? I would say if I would talk about shared decision-making process, and if she says, yeah, I want to do sinus surgery, I think it's reasonable to do sinus surgery, but I would say definitely want to control her asthma better to make sure she can tolerate the anesthesia. And so the next question is, a biologic a reasonable option? And I would say yes. I mean, she's already had sinus surgery. They've already been on medical treatment after the surgery, and the polyps are starting to come back. So is she a candidate? I would say yes. I think it's definitely reasonable. And of the three biologics that have been approved for nasal polyp, dupilumab and omalizumab is an option because the patient has a type 2 and high eosinophils. IgEs being on the low side, maybe not the best decision. So definitely talk to the patient about shared decision-making process. And so after you put the patient, so let's say for Angela, we put the patient, she says like, I don't want to do sinus surgery again. And are there other treatment options? And she wants to do a biologic. And if you put the patient on biologic, certainly you want to confirm that they have nasal polyps. And like I said, if they had sinus surgery and have polyps come back despite appropriate medical treatment afterwards, they're most likely going to have asthma. So I think that's why it's very important. This euphoria guideline is very consistent with that multidisciplinary approach for the treatment of nasal polyp, that it should be a multi-specialty approach, and I think it makes a lot of sense, and it provides better treatment options for our patients. And then, similar to the other nasal polyp algorithm paper, the Euphoria also says that, after a patient is started on a biologic, you want to reassess them in 6 months. And you want to look for different symptoms as well as objective measures, whether it be increase in smell, improvements or smell, nasal congestion, polyp score, or SNOT-22 or VAS score. And I think the VAS score is much easier for patients to interpret as well as even for physicians. While SNOT-22 is 110 questions, so it's a lot of questions to, it's 22 questions, so it's a lot of questions to answer. So the VAS score is just one question you can answer. And then if they get better in 6 months and they have improvement, you can continue them on it and then reassess them in a year. If they don't have improvement, then you can talk to the patient about different treatment options again. So this is where you talk to them about the shared decision-making process again and say, do we want to do surgery, maybe change a biologic, or consider other treatment options. And then you want to reassess them at 12 months. And again, as we mentioned, you want to reassess them initially at 6 months, and then you want to reassess them at 12 months and see how they're doing. And if they're doing well, continue them on a treatment option. And if they're not, again, you bring up the shared decision-making tool to talk to them about what you can do next for the patient based on the patient's interest. And so, the one of the question that probably comes up, or that a question that comes to your mind is, how do we differentiate all the different biologics for nasal polyps? And right now there are no head-to-head clinical study looking at one biologic versus another. Now there is a clinical study that's going on right now, that's currently underway, but there's none that's been completed yet. But as we summarized earlier, dupilumab is an IL-4 receptor antagonist that blocks IL-4 and IL-5, which are key drivers for type 2 inflammation. So if someone has CRS with nasal polyp that has a type 2 disease, I think dupilumab is a very good option. If someone has nasal polyps and they have elevated IgE, I think that omalizumab is a very good option for these patients, because omalizumab blocks the IgE from binding to the mast cells and basophils, and then decreasing the decreasing the inflammatory cytokines that get released from these cells. And mepolizumab is an IL-5 antagonist. So, I mean, we know that IL-5 and eosinophils go hand in hand. So, if these patients have nasal polyps that are driven by eosinophils, I think mepolizumab is a reasonable biologic to treat for our patients that are driven by eosinophils or associated with eosinophils. So to kind of summarize what we've talked about, we talked about what causes what causes CRS with and without nasal polyps, and I think we certainly have a better understanding of it. Certainly, having these biologics available for our CRS with nasal polyp, I think really has allowed us to get better understanding of how CRS works. And so I think the biologic has really helped us better understand nasal polyps. And then, understanding what are driving the endotype or the biomarkers that are responsible for the creation of nasal polyps, I think it makes sense that biologic should be in the treatment algorithm. And there are new and other treatment options that are currently being developed for CRS with nasal polyp, and I think it's a very exciting time. So if you have CRS with nasal polyp, I think it's a great time, because the biologic really is a new class of treatment options that we have for our patients that are difficult to treat. And so I think with the introduction of the biologic, I do think that it will decrease the prevalence of recalcitrant CRS with nasal polyp, and I think it will continue to get better and better. So now let's do some of the post-test questions. So nasal polyps are generally reveal pathogenic proliferation of which inflammatory cytokine drivers? So is it interferon gamma and TNF, IL-6, IL-5, IL-1 and IL-6, IL-4, IL-5, and IL-13, or IL-12, IL-17, IL-13? So go ahead and choose your answer and submit it. So let's go to our next question. The immunologic nature of CRS with nasal polyp is typically characterized as type 2 inflammation driven by eosinophils. How many patients with severe disease show which of the following? Um, Higher levels of type 1 and type 1 inflammatory cytokines, more neutrophils than eosinophils, mixed levels of eosinophils and uh, neutrophils, greater number of macrophages and CD8 and T cells. So go ahead and submit your questions. Submit your answers. I'm sorry for the question. So next question, woman in her late 30s present with nasal polyp and a history of eosinophilic asthma. She has low IgE levels and doesn't want surgery. Which treatment would be most appropriate? And so this patient has nasal polyp, eosinophilic asthma, has low eosinophils. Which one would be a reasonable treatment option for this patient? And so go ahead and submit your answers. And so the next question is, this is a 49-year-old man with a severe nasal polyp and scheduled for sinus surgery next week to have the polyps removed. When should he first be reassessed for response for the treatment per the euphoric guidelines and the multidisciplinary consensus algorithm? So if this patient has CRS with nasal polyp, is undergoing sinus surgery, and was given a biologic, at what point would you want to reassess the patient after the patient started the biologic? And so go ahead and submit your answer for the question. So here's another question. A 53-year-old man with severe nasal polyp has undergone sinus surgery twice. So he had sinus surgery twice. And after the last sinus surgery, within a 12-month period, um, is trying one of the biologic. After 12 months of being on a biologic, he doesn't seem to have inadequate, he appears to have an inadequate treatment response per the euphoria guideline. And he believes that sinus surgery was a waste of time because he's had two sinus surgery and had polyp recurrence. So he's had two sinus surgery, has been on a biologic for about a year, feels like it's not getting better. So what would be the most appropriate recommendation based on the shared decision making and consensus guideline? So if he's not getting better after two sinus surgery, doesn't want surgery again, another third sinus surgery, has been on one biologic for 12 months and is not getting better after a 12-month period, what would you do next? So this is according to that paper on the euphoric guideline. And so go ahead and select your answers. Okay, so that's the end of our post-treatment questions. Now is time for Q&A. So if there's any question, feel free to type in those questions, and I'll be able to see it and answer those questions. So a question came in. So how big of a role should the total IgE levels and eosinophils play a role in choosing a biologic? And I think that's a great question, especially for nasal polyps. So for asthma, we know that the biologic um, for asthma is really dependent on total IgE as well as blood eosinophils. But for nasal polyp, it doesn't seem to be one of the criterias that you use to get a biologic approved for our patients. But personally, as a clinician scientist and seeing a lot of patients with nasal polyp that are refractory, the average number of sinus surgery before a patient comes to see me has had 2.3 sinus surgery before they come and see me, and they've been on all the different medical treatment options, small molecules, topical steroids, and still not getting better. So for these patients, these are pretty severe patients. So, and they often most commonly have comorbid asthma. So I think for these patients, I do measure total IgE, specific IgE, as well as blood eosinophils to help me kind of better understand who they are. So if these patients have really high blood eosinophils, like 3,000, 2 or 3,000, or even above 1,000. I mean, you have to kind of wonder, how much is the eosinophils really driving the process? We've had patients where they have severe nasal polyps where the IgEs are over 1,000 as well. That, the upper limit of normal usually for total IgE is about 100. So when these patients have total IgEs over 1,000, you got to think that it's got to play a role. And so I do it. I do draw the total IgE, specific IgEs, and blood eosinophils because, I mean, in a way, by drawing these laboratory tests, you're kind of endotyping these patients and trying to better pick, which biologic may be the most appropriate for these patients. So I do it, and I think it does play a bigger role. Although for insurance purposes, I mean, certainly these are things that you don't necessarily need to do, except for omalizumab and nasal polyp, because omalizumab, you do give the dosing of omalizumab for nasal polyp based on body weight and total IgE. But you also have to remember that these total IgEs and blood eosinophils can be artificially decreased by giving them systemic steroids. So you have to pay attention to that. Thank you for that question. Right. So if there's no other questions, I'd like to thank you for joining me. And so for additional resources, information regarding CRS with nasal polyp, please visit the integrityce.com/NP resources. And so now you will be redirected to the evaluation to claim your CME. Now redirected to the evaluation, or you can claim your CME credit at this website, integrityce.com/CRS with nasal polyp P eval